My name is Mohammed, and I'm one of the ICM trainees who recently started in February. I'm going to share a case with you, which I looked after on a night shift. I found interesting. I hope you also do. A few bits and pieces to talk about while we're going through. So it's all started just after the night handover. I got a referral from ED, about a 33 years old lady, normally healthy apart from being on the overweight side. So her weight was 135 kilos. Just seasonal asthma, but she never used her salbutamol inhaler for years now. It's all started 3 days ago by having perineal boil. She went to GP for it and prescribed some flucloxacillin and paracetamol. It didn't get better in terms of pain, and this morning she felt unwell, lethargic, with high temperature, and she vomited twice. And her family found her less responsive, so her husband brought her to ED. And based on the presentation, the ED doctors referred her to surgical reg, who came and assessed her. She had a look in the perineal abscess, and she says it was very tiny. It's unlikely to be the cause of the clinical picture. She may need IND at some point, but it's not urgent at all. However, she looked mottled, unresponsive, and she was clammy. She was a bit tachycardic with a heart rate of 130, and she's very, she was unresponsive and not engaging in conversation. So she asked for an ABG and ICU to see her. She also did a vaginal examination, which didn't show anything significant, but there was a significant bleeding coming out afterwards. She also discussed with the gynae, and they weren't interested. They said it's nothing for us to do. The ABG was a bit interesting. So she had some metabolic acidosis, pH 7.2, with lactate significantly high, 9.3. She's a little bit hypokalemic, 2.4, and glucose with 0.9. We didn't know why. We didn't figure out what's the cause for that, but we obviously given her glucose, and she woke up after that, but she still doesn't look right. We clarified with the family any history of insulin intake, any possibility of overdose of some things, suicidal attempts, mental health. All looks clear, and we didn't figure out why her glucose is that low, neither why she had metabolic acidosis and hypokalemia in someone who's young and medically fit. So the surgical, you start ask for CT, chest, abdomen, pelvis to look for any septic focus, just like a septic screen, because this abscess doesn't explain anything. Her blood came back from ED, so had a little bit of high white blood cells. Her platelets were significantly low, 18, INR and PTT prolonged, and slightly deranged liver enzymes. Creatinine is a little bit on the high side. So we decided to take her to intensive care. So we said we'll do the CT chest abdomen, and we'll take her to intensive care. This is no surgical cause, just to correct the acidosis, correct the potassium as HDU kind of thing. So the CT chest has been reported as normal. CT abdomen said there's a slightly enlarged liver. There's gallbladder wall edema, but didn't suggest cholecystitis. There's some lymph nodes in the abdomen, most of them peripancreatic. The largest was 1.3 centimeters. And the abscess we spoke about, unfortunately, it hasn't been completely scanned. So not the whole perineal had been scanned, but the part has been scanned as reported as there's a perineal abscess with 5 by 6 centimeters. But they didn't mention anything else about it. So we admitted her to ICU. She wasn't bad, actually. So this main thing is just to figure out why she had lactic acidosis and correct the potassium. I can remember why she's being wheeled in the ICU. The nurse in charge said she looks well. She definitely doesn't. She doesn't seem unwell to be in ICU. She's not even on oxygen, and that was right. She was talking. She was all right. So ABC, airway was all right. She was on oral saturating 100%. Respiratory rate was a little bit high. She remains tachycardic and blood pressure was borderline. She was fully conscious, talking, but she was in pain. She was lying in her right-hand side like every other patient with a perineal abscess. If you do emergency theatres, they all will do like that from the pain. And she didn't wee since coming to ED. And her temperature was normal. So we start fluid resuscitation. We treat that as sepsis based on the high white blood cells, low platelets. We thought it might be sepsis of some sort, might be this abscess, might be something else. So from being presented to ED till the ICU, she received 5 liters of crystalloids in total. We started the empirical antibiotics. Blood pressure wasn't actually responding, actually it's getting worse. So we started her on metronidazole. She went very quickly on a very high dose. So I remember from nothing to like 20 miles per hour in maybe half an hour. But she remained off oxygen and lactate got worse to 10.8. And she remains anuric. We thought about putting some lines in her, central line and arterial line. Just reminding you the bloods, her platelets was 18, INR was 2.2, and PTT prolonged. Anyone have an idea? Would you put the line in someone like that?
I would.
Yeah, okay. So we thought about it. Let's see the recommendation. So actually there's no clear cut below which you cannot put central line and arterial line in terms of coagulation. But most of the literature will be more interested in platelets rather than INR, because low platelet count or dysfunction have higher risk than deranged INR. But again, looking at the platelets, there's no clear cut that you cannot put central line below that. So it all comes back to risk versus benefit. If you look at the NICE guidance, they recommend platelet transfusion to reach 50 before putting invasive lines. But there's lots of talks about 20 to 40, and 50, but the least I've seen is 20. So we asked for platelets, but unfortunately we were in a DGH and the platelets comes from somewhere else and it will take 2 hours to arrive. So we decided just to line her up. So there's central line, arterial line. It went all right, but she was very oozy from even the stitch sites. And we've taken bloods from these lines immediately after putting it, and everything looks way worse. So INR was unreadable, more than 10, PTT more than 180, so it's all out of the range of the lab that can read. White blood cells jumped to 19, severe AKI, 170 creatinine, ALT, bilirubin, GGT all went off, fibrinogen and D-dimer was the range. This, we're talking about 2 hours between the two bloods, so it's just 2 hours literally. So I thought something's not right there, and we looked at the coagulation. So low platelets, high INR, high PTT, low fibrinogen, severely deranged D-dimer. This looks like DIC. So what's DIC? DIC is a acquired syndrome, happens by activation of the coagulation pathways, and usually results in intravascular thrombi and consumptive depletion of the platelets and coagulation factors. Lots of causes can lead to DIC, like sepsis, trauma or burns, some malignancies. You can see it a lot people who anesthetists who do OBS, so obstetrics disorders like amniotic fluid embolism, eclampsia, all of that can lead to a DIC. And any severe organ failure or some toxins and immunological reactions. So there's lots of things. Most commonly we see in ICU sepsis. How these patients present in DIC, they either present with signs of bleeding or signs of clotting. So ecchymosis, petechiae, or gangrene, hypoxia, and hypotension. How to diagnose it? So you need a causative agent, one of the causes we mentioned, plus abnormal coagulation tests, which in form of low platelets, low fibrinogen, and deranged clotting, high PTT, and high D-dimer and FTPs. Usually you treat it by treating the underlying cause and symptomatic. If they're bleeding more, we give them something to stop bleeding. We have a patient here in the unit now, DIC, we talk about in the morning. So sometimes you get them FFP, platelets, antithrombin free if they're bleeding. If they're a high risk of clotting, you may give them heparin on the other way, which we're doing with our patient in the unit now. This patient we're talking about is more risk of bleeding. She was oozy everywhere. And DIC can lead to life-threatening complications like hemorrhage or life-threatening clotting, like gangrene or loss of digits. Back to our patient, she's now lined up, giving her loss of fluids. Again, antibiotics were started already. We switched the metterminal to NORAD, started her on steroids for sepsis dose. Currently, her MAB is barely above 65, and NORAD requirement is going up very quickly. This all within the night shift, so just few hours. Lactate is actually worsening, went all the way up to 13 despite active resuscitation. She had them think in total like 8 or 9 liters within a few hours. But she remains still off oxygen and she's olipuric. So we thought we're not winning there, giving her everything. We think it's sepsis. The surgeons are not interested in the sepsis. We don't know where is it coming from. We don't know what's going on. So we started again looking at the bloods, looking at the clinical picture and to see what we are missing. So started calling everyone. So we spoke to hematology. This lady has a features of DIC, bleeding on PV and resus, and she's oozing from the line what to give. They recommended FFP, 5 units, cryoprecipitate, and platelets. 5 units looks a little bit too much compared to what we're doing here. But if you look at the recommendations of transfusion, in DIC FFP to correct the platelets, FFP is the preferred agent to give to replace fibrinogen if the fibrinogen is less than 2.9. And usually the adult dosing is 12 to 15 mL per kg. So an average adult, they will usually like 5 to 6 units usually. But you can speak to hematology, they may advise something else. Cryoprecipitate, this is the second line after FFP, and the usual adult dose is 2 units per adult. Platelets, the recommendation is to transfuse less than 20 or less than 50 if they're actively bleeding. So, and usually to give just 1 pool and reassess. This is a British Society Hematology recommendation about the transfusion. So spoke again to surgical registrar. This patient is actually deteriorating. We're not winning with her. We're giving everything we can. Can it be neck fasc? He said the CT doesn't suggest features of neck fasc, and she's too unwell for any surgical intervention now. However, we can do needle aspiration, but you need to correct the coagulation first. So do whatever the hematology asks for, correct her bleeding, and I'll come back to do needle aspiration. But again, try to find something else. Unlikely this small abscess can explain this clinical picture. And even I spoke to Birmingham Liver Center, saying this patient has acute presentation. She had a prodrome of fever, vomiting, and she was severely hypoglycemic on admission. She's been prescribed Floclox and paracetamol. There's no evidence of overdose, but I cannot confirm it. She's a bit lethargic. She had deranged clotting. She had deranged liver enzymes. Lactate is very high. Bilirubin is high. AKI, and she's shocked, which is not explained by surgeons. Can this all be acute liver failure? She ticks most of the boxes for acute liver failure. Can we give NAC? Is she a candidate for a transplant? She's young. She's previously well and fit. So we went through the history, went through the bloods over the phone, and he said, given what happened, it's unlikely to be the liver is the primary problem, slightly secondary to sepsis. So she has DIC, which caused AKI, liver problem, and all secondary to sepsis. Try to find out the source. The liver is not the problem now. So okay. Back to our patient. She got more stable after transfusion of products, and no other requirements remained stationary. We couldn't wean it down. She had a total of 5 FFP, 2 cries, and 1 platelets. And we called the surgical registrar to come and do the needle aspiration. He came around like 2 o'clock in the morning. And on his arrival, before touching the patient, the abscess burst. And there's huge amount of pus came out and loss of necrotic material, which doesn't look like normal abscess. Some tissue material in it, That's all came from the vagina. The surgical registrar had a look on that and said it definitely looks like Nick Fash. It's not a normal abscess. We have to take out the features now. So he spoke to his surgeon, his consultant, and the anaesthetist, and they came to assess the unit and took out the features. So what's Nick Fash? This is not hair, by the way. It's just a picture from BMJ. So Nick Fash is a life-threatening subcutaneous soft tissue infection that usually requires high index of suspicion to diagnose. It's often very difficult to diagnose. It's quite rare to happen, so it's very easy to be missed. When to diagnose it, when to suspect it, if the patient is rapidly deteriorating, like this patient, as you can imagine, from 8 o'clock to 2 o'clock, she's a completely different person. If the patient is rapidly deteriorating and some features suggesting like severe pain, which is usually disproportionate to the clinical finding. If it happens on the skin, like in arms, legs, you may find anesthesia of the site of infection. There will be erythema and edema, but usually edema happens first and tends to be beyond the erythema, which is quite characteristic because all the infection comes from the subcutaneous tissue. So the edema will extend beyond the erythema usually. And there will be systemic signs of infection. However, which is very important, neck fash can be easily missed because the patient may present earlier, like this patient, and with non-specific symptoms or signs. How often we see neck fash? It's very rare. I'm not sure if you have seen enough. I've seen 4 in total. Unfortunately, this is the only one survived. The epidemiology says that 500 patients present to the UK hospitals with neck fash each year, which means like half a case per 100,000 population. So it's quite rare. What are the risk factors for a patient to develop neck fash? There are strong and weak risk factors. The strong ones is inpatient contact. If the patient has been exposed to another patient in hospital with strep A infection or any other causes for organism, maybe. Varicella zoster infection thought to be one of the strong risk factors. Any port of entry like skin injury, surgery, trauma, and IVDU patients. On the weak risk factors list, we find chronic illness, any chronic illness that may make the patient immunocompromised or vulnerable, immunosuppression of all sorts, most commonly malignancy and steroids. The use of non-steroidal anti-inflammatory is quite questionable. So people may say this may mask the symptoms and make the diagnosis late and increase the risk of death. And it may have something to do with the cytokine inhibition as well that non-steroidals will do. Microbiology, what bugs we can isolate from neck fash patients. Usually when we say neck fash, we think of screw-based strep. But it's not actually the most common thing. So the most common organism to be isolated is polymicrobial infection. And they divide neck fash into types depending on the microbiology. So type 1 and 2 the most common. So type 1 is usually polymicrobial, which consists of anaerobe, either Bacteroides or Streptococcus, plus one of the facultative anaerobes like Enterobacteriaceae, plus or minus Staph aureus. Type 2 is usually monomicrobial, it's less common, but by far the most common in this type is strep A infection, strep pyogenes. PVL positive Staphylococcus as well can cause it, and MRSA. Type 3 and 4 is quite rare, so type 3 is again monomicrobial. Some of them will be associated with freshwater exposure. The organism will be Aeromonas hydrophilia, or the other type, saltwater exposure or consumption of raw oysters, and will be Vibrio. Type 4 is usually fungal, and it's very rare. The presentation can be either fulminant, acute, or insidious. Fulminant, like this patient's, the most severe and carries the higher mortality, and characterized by extensive necrosis, and the patient will be systemically unwell within few hours. On the other hand, the acute, it happens over days and maybe initially systemically well, but they will deteriorate over days. The insidious onset is less common and they present with non-specific symptoms and signs, and it's very difficult to diagnose. And the pain might be mild or even absent. Because the most common site of neck fascia is limbs, it's very easily to be misdiagnosed as cellulitis or mixed with cellulitis. So there's a few bits to differentiate from cellulitis. So the pain in neck fascia will be more severe, and you may find anesthesia over the site, which you won't find in cellulitis. And the pain will be way disproportionate to the skin changes. The skin changes itself may have crepitus, vesicles, bully, grayish discoloration, and the edema is extending beyond the erythema, which you won't find in cellulitis. But again, this patient can present with normal skin, and this is very important in group A strep. So the patient may even get intubated on very high doses of NORAD without any skin changes. So the skin changes in strep A can be very late. And there's some atypical presentations which happen in 20% of the cases without any skin changes, especially that arise from baffling glands or perianal abscess like this lady. And there's a special form of neck fascia, fournier gangrene is considered as neck fascia as well. What investigations would you do? Again, it's very important to realize that neck fascia is a clinical diagnosis. However, you can do some investigations to help the diagnosis. And characteristically, you find some gas, which is in the tissue, which will be suggestive of neck fascia. CT is usually the best choice. CT and MRI is very sensitive. However, MRI is very difficult to arrange in emergency situations. You can do X-ray, but you cannot rule out neck fascia with that because usually the gas will be a late sign and it's not as sensitive as CT. There's some talks about ultrasound, with ultrasound if the patient's too unwell to go to CT. And actually it has good sensitivity and specificity of 88 and 93%, with some findings including thickening of the subcutaneous tissue and fluid accumulation within certain depth. So you can ask for ultrasound of your patients very unwell. Going back to our patient, this has CT, so you can see clearly there's gas in the abscess, which unfortunately hasn't been reported by the radiologist, and it's been overlooked by us and the surgeons as well. Usually when we look at the CT images, just after chest, we lose interest. But it's very clearly there's gas there, and if we saw that from the start, it would be highly suggestive of neck fascia. But I'd say the patient saved her life by bursting this abscess. So the first, second, third, fourth line are emergency surgical exploration. If the patient didn't do that, they will not survive, usually. I've read something about something called finger test. If you're in doubt about the diagnosis, there's a bedside test you can do. So it's a surgical method to perform. You give local anesthesia, you do 2 centimeter incision, but it's quite deep to the deep fascia. And there's quite features that suggest neck fascia, like if there's minimal resistance on finger sweep, if there's absence of bleeding on incision, if there's necrotic tissue came out, or there's grayish fluid came out. Antibiotics is very important, but again, it comes after the surgical exploration. So what you start usually empirically to cover type 1 and type 2. So the treatment combines broad spectrum antibiotic like tazocin, meropenem, cephalosporins, fluoroquinolone, like ciprofloxacin, one of these, plus something to cover MRSA like vanc, linezolid, or daptomycin, plus something to inhibit the strep A toxin. The evidence all goes towards clindamycin. So the treatment or the antibiotics will be like tazocin, vancomycin, and clindamycin, for example. Type 3 and 4, there's no recommendation to cover them empirically. Empiric antifungals are not recommended. There's some talks about hyperbaric oxygen and neck fash, but there's lack of strong evidence, and in the UK, still not recommended as a routine treatment for neck fash. Some countries recommend hyperbaric oxygen for neck fash, but again, this shouldn't by any means delay the surgical intervention. This slide just to know that these exist. So there's a scoring system for neck fash. It's called laboratory risk indicator of neck fash, which is basically you put some lab findings and tells you what the possibility of neck fash. But again, neck fash is a clinical diagnosis. You cannot exclude it with this scoring system, but just to let you know that this exists. Possum score in neck fash, people can use it to determine the mortality, and there's a recommendation if it's more than 10% mortality, this patient should be looked after in ICU. So this might help your decision to admit to ICU. Why we're talking about neck fash? Because it's a life-threatening surgical emergency with very significantly mortality rate. So if you did everything right, if the patient got surgical treatment, she got antibiotics on time, she got everything that she should get, they still have 10 to 40% mortality rate. If they went into multi-organ failure or shock state, the mortality goes up to 50 to 70%. Even if they survived all of that, they will have long-term problems with the skin loss and scarring, which usually will require reconstructive surgery, because they will debride plenty of skin. So back to our patient, she went to theater around 3 o'clock in the morning. She had hypoxemia and induction. She has high BMI, which was expected. They found the whole posterior wall of the vagina is necrotic. They've taken tissue culture of it, and they packed the vagina with a plan to go back to theaters in 24 hours. Just to make things a little bit worse, she had a cardiac arrest just after procedure, very short for 1 cycle, and we didn't figure out why. Maybe just part of unwellness she was in. She transferred to ICU sedated and came back around 6 o'clock in the morning. The gram stain came back. She had polymicrobial, so she had type 1 of neck fash, gram-positive cocci, gram-positive bacilli, and gram-negative bacilli. The antibiotics overnight, we start tazocine, clindamycin, vancomycin. In the morning, after exclusion of type of strep A, it's been de-escalated to meropenem and linezolid, and further down the line, it's just meropenem after exclusion of MRSA. She went back to ICU, sedated, ventilated, hemodynamically much better, but she remained on NORAD. But she's still acidotic with high lactate, oliguric with AKI3. Inserted vas cath and started RRT, all of that overnight. And then she had multiple visits to theaters, I think 6 in total, for repeated debridement, and everything improved after that. Liver, kidney, hemodynamics. She extubated, and a few days later she went to the ward. 3 days later she was at home. Take-home message: if you think neck fash, immediately refer to surgeons before waiting for any blood tests, before waiting for any CT or X-rays. Do not wait for any investigations. Neck fash is a clinical diagnosis. Investigations can support it. Surgical debridement is the first line of treatment, and you should go to theaters as many times as is required to remove all the necrotic tissues. The recommendations is repeated visits to theaters within 12 to 24 hours. Antibiotics and supportive care is very important. Start IVM empirical antibiotics as soon as you can. And there's evidence that delayed debridement after 12 hours of admission will have very high risk of mortality and organ failure. Any questions? Anything you want to raise or learning points? Share cases you have seen.
I had a case of a lady who she had neck fash, but she'd basically was on holiday. She's like 40, fit and well, and she was on holiday, and the zip of her boot, when she did up the zip, had just caught her skin. You know, a very, very small little cut, but because she was on holiday, she was going swimming in the sea and swimming in the pool, and it got infected. And by the time she got home and came to hospital, it had progressed up her leg, and then it basically it just kept progressing, and they kept dividing more and more. But she died in the end.
Oh, yeah. Yeah, I've seen 4 in my career. This is the only one survived. I mean, till discharge. Few of them had multiple development, but they died at the end as well. It's very, very important to diagnose them early and refer them.
High index of suspicion.
Yeah. I think what helped as well that she's young, she's not comorbid, and she managed to survive that. But imagine all of that happens just in 12-hour shifts, so they can deteriorate really, really quickly.
You said not to start empirical antifungals, but again, if you don't test for them, you'll never find out if it's fungal. So
yes.
You need to specifically request an fungal.
No, well, there's no recommendation to start empirical antifungal. However, the first go to theatres, they should take tissue culture. So the tissue culture will show what organism, including fungals, including MRSA, including everything, and you should direct your treatment accordingly.
Only if it's positive.
And surprisingly, fungal neck flash is not related to immunocompromised patients. There's lots of cases reported with immunocompetent patients had fungal neck flash. But again, it's still very rare, extremely rare to put it as an empiric therapy to start with. All right, looks like no questions. Thank you very much for listening. Thank you for your time. And hopefully you'll get a feedback later.
Hi, everybody. I'm Shabali. I'm one of the CT1 anesthetic trainees. I'm going to be presenting this paper that I recently presented at the LGH. This has got an anesthetic slant to it, sorry. But it's a really interesting meta-analysis that was published in one of the more recent BJAs at the end of last year about hypotension and post-operative outcomes. And it shows it because it's received a lot of letters to the editor about this paper, because it's also just relevant for me as I'm starting out. I always wonder kind of what blood pressure to run my patients at. So a little bit of background is that we know we need a good intraoperative map of kind of between 60 and 70, or above that, sorry, because we know that if patients are too hypotensive intraoperatively, they have myocardial injury, AKI, and death. And a bunch of important people met in London, and they had this perioperative quality initiative. And they made this consensus statement where they looked at all the evidence and they said that these problems are a function of the hypotension itself. So they're directly related to how bad the blood pressure is and how long your blood pressure was low for. So we know that, okay? And that's all based on observational studies and meta-analyses of observational studies. What we don't know is whether there are patient-specific thresholds. So someone might tolerate a lower MAP than another person, dependent on their natural physiology and also their age, for example. And what we also don't know is hypotension actually causing any of the adverse events that we're seeing, or is it actually more of a marker? For example, somebody who's more likely to become hypotensive is already super frail, and so because of that frailty and underlying problems, they're the same kind of person who's going to end up having complications. So we don't know that, and there isn't really a good way of showing it either. We also then don't know if I try and aggressively treat their low blood pressure, by giving lots of inotropes or lots of fluids, what exactly is the harm from all of those treatments as well? So it's a balance. So to briefly take you through the paper, their research question was to try to compare permissive management versus targeted management of blood pressure intraoperatively. So they looked at patients who were having cardiac and non-cardiac surgery, so all surgeries basically, and they were comparing randomized controlled trials. They were comparing whether there was a patient group that had permissive management, so their MAPs were allowed to fall below 60, versus targeted management, so their MAPs were allowed to go above 60. And they looked at all-cause mortality at the longest follow-up available. So important couple things over here. They looked at the strategy of blood pressure management. So they said, okay, here's an RCT comparing, we're going to try above 60 or below 60. They didn't actually check what the resulting pressures were. They were comparing what the targets were. And then, yeah, they looked at all-cause mortality, and the follow-ups were really different. So, yeah, they looked at randomized control trials. They pretty much included all GAs. They didn't talk about whether they were using specifically emergency or non-emergency or all. And they looked at studies that also, they excluded anything that wasn't an RCT, basically. Okay. So in the end, they ended up with 10 studies. And they had this data collection form where they checked everything. So, okay, this part of their data collection was pretty robust. It was good. Their outcomes, what I was going to comment on was they just looked at, I'm not sure that was the greatest thing to look at here, because we want to look at things like delirium or AKI as a result of hypotension or MI, but they just looked at mortality mainly. And then they did a Cochrane's Q test, and they used basically they did all these statistical tests, and I'll take you through them. They also then did a risk of bias assessment, which is something you have to do when you do a meta-analysis for every paper. So they're trying to see, okay, in each paper we used, were there any biases? And then we can weight those papers less if there were biases in those, okay? They also used GRADE for quality of evidence testing for their primary outcome of mortality. These were all the secondary outcomes they looked at. So the incidence of atrial fibrillation, AKI, delirium, stroke, things like blood transfusion, length of hospital stay. Since their primary outcome was mortality, I thought I would go and show you. So I looked in their appendix. Out of the 10 studies they looked at, look how variable mortality is. So sometimes when you look at a meta-analysis, it's important to check where is their data coming from. So they're telling you they assessed mortality, but that ranged from 7 days to 1 year. And in one paper, they didn't report it at all. So that, or actually it ranged from, yeah, it's a massive range essentially. So it's maybe not as useful. Their risk of bias assessment was using this ROB2 tool. There's lots of different tools you can use. This is a Cochrane-based one, and it basically gets the investigators to look at each paper, and it asks them a series of prompting questions like, do you think in this paper's study protocol, was there bias from the randomization process, for example, blinding, or missing data, measurement of the outcome? So it gets them to grade everything based on high risk of bias, some concerns, or low risk of bias. So they did that for every paper, and then at the end, they give them an overall score, and they're considered a low risk of bias only if every single domain is low risk. So that's just to show you how you can do that in a meta-analysis. And here's their results. So they had 10 trials, which resulted in just over 9,000 patients overall over kind of a 10-year period. And just for interest, they were kind of from all over the world. 6 of them were specifically in a cardiac surgery setting. And importantly, I wanted to show you this. So the MAP target in the hypotensive group was between 45 and 60, and apparently between 61 and 100 in the normotensive group. Okay, so essentially they were looking at, is there a difference when we're aiming for a MAP below 60 versus above 60? But if you then went and actually looked at the papers that they used within their analysis, only 4 papers actually stuck to these targets. So again, the data, you know, they're telling you this. We have a bit of evidence here from 9,000 patients, but really, if you look at what was achieved, it wasn't the target. Okay. So what they ended up concluding from their results is that there was no difference in mortality if you used a permissive management strategy versus a targeted management strategy for blood pressure intraoperatively. And they're showing you the odds ratio is 0.88. Okay, so it's less than 1. The confidence interval 0.65 to 1.18 spans 1. So that again shows you that it's actually probably not that statistically significant to us. And then in their secondary outcomes, interestingly, they said that if you use a permissive management strategy for intraoperative blood pressure, and you let your patients be low, then actually you had less atrial fibrillation and a reduced length of stay. That's what they're saying. So they're pretty much saying there's no difference in mortality, but you might have less side effects, less atrial fibrillation, etc. And they found the same results when they analyzed the cardiac surgeries versus non-cardiac surgery subgroups separately. So these results are really problematic because here they're basically trying to tell you it's okay if you let your patients become hypotensive, and actually they might have less atrial fibrillation and less hospital stay, which is quite dangerous to suggest if their actual methods, as I showed you, weren't great. So this is a summary. I appreciate it's long. You don't need to look at this. I will highlight the important bits, but this is a summary of the 10 papers they looked at. So 3 of these papers only employed their blood pressure management strategy during cardiopulmonary bypass. It wasn't throughout the procedure. So it was during a very specific time. Okay, so that also makes it a little bit irrelevant. There were 3 papers that were looking primarily, 4 papers that were looking at AKI, 3 that looked at it primarily. Looking at those 3 papers specifically, they said that if you allowed permissive management, you didn't see any change in AKI or not. Okay, so that's useful information. There were a further 3 papers that looked specifically primarily at delirium, and they said, which is not surprising, that if you were strict with your MAP targets, that your patients had less delirium and cognitive dysfunction afterwards. And then this is the other most important thing. So in their analysis, in their risk of bias, and because of how many patients were in each trial, they actually gave 53.3% weighting to this one paper published last year with 3,700 patients. So that's close to half the N of total. And in this paper, their primary outcome was vascular complications. So it wasn't actually about mortality in the first place, yet our primary outcome is about mortality. So most of their evidence has come from this one paper, and their primary outcome is not our primary outcome. So I'm just trying to illustrate why it can be problematic to look at something even as good as a meta-analysis and think, okay, that's good evidence because they've looked at nearly 10,000 patients. But if you really look at the methods, you can see that it's really misleading. Yeah. So this is that paper that they based 50% of their weighting on. And interestingly, their blood pressure management strategy was not below 60 or over 60. It was over 60 or over 80. So they based their conclusion, which is you can aim for a MAP under 60 or over 60, mainly on one paper that didn't even use that target. They used over 60 or over 80, which is actually much safer. Okay, so it didn't even fit. And I think that's crazy that they did that and published it in the BJA. So all the 10 papers that they used, these were the targets of within each RCT. So people were targeting kind of here, below 60, you can see, or above. And this is what they were actually achieving, not the targets, but what was actually achieved intraoperatively. So you can see here the line of 60. So only 4 papers showed that they achieved an intraoperative MAP below 60, which was the research question. 3 of them, including the one that's 50% weighted in this paper, didn't even report what they actually achieved intraoperatively. Okay, and here's just to show you that, again, they're trying to tell us that your patients will have a reduced length of stay if you let them run hypotensive, and 98% of that weight comes from that one paper where they used a completely different strategy. So the positive bits about this paper is that it was the first meta-analysis that looked at randomized control trials on this topic. They had a good search strategy that they followed PRISMA guidelines. They used all these tools, the GRADE and ROB tools to talk you through. And they did give us a nice table that summarized that 3 studies agree that hypotension is related to delirium intra-op, and 3 studies agree that it doesn't actually change your AKI. So that bit was useful. They just kind of summarized the data. But again, it's just to show you that even if you do all of this stuff, you can still be really misleading, depending on how you include your papers and how you use these tools and how you weight them. So I won't go through this because I've told you most of it, but the time points of mortality range from 7 days to a year. There was there were so many differences with all of their outcome measures as well. So how do you classify an AKI? And yeah, I've told you the rest of this already, actually. The other main thing to comment on is their analysis was limited to the intraoperative period. So they didn't actually look at what was your blood pressure for 1 or 2 hours after, or, so that's also important, like during recovery. Other weaknesses in the data, we don't know how they're monitoring blood pressure intra. So if it was every 15 minutes, they were checking a non-invasive, then you might have missed, a time where they were really hyper or hypotensive. And yeah, I've told you the rest already. They had really diverse map targets between papers. Okay. Another really interesting thing is there was one research group that actually took all of their data, reanalyzed it in their own R system, and got completely different results. So they said that their analysis was wrong and erroneous with the same data set. So how did they try to explain it? Because they actually published this and said you can be free with your hypotensive, you can be permissive with your hypotensive strategy. So in their discussion, they tried to say that maybe we aren't considering the adverse effects of having really tight blood pressure management, and maybe that increased bad outcomes or mortality in the tight blood pressure management strategy. Like fluids could overload people or push them into heart failure. Maybe if we use a lot of vasopressors, that related to a higher incidence of atrial fibrillation in the other group. And they also tried to say that maybe low blood pressure is good for reducing surgical blood loss. They also tried to say that, okay, there is bias in all the studies that connect hypotension with worse outcomes. And this is what I was talking about before, yeah, because perhaps if you are already frail and comorbid and you're more likely to have a bad outcome, you're also more likely to become hypotensive intraoperatively, which we've all seen. So perhaps those two things are already linked anyway. But what we don't know is if hypotension is a causal predictor. Okay. The other thing I read in the literature as well is that actually 1/3 of patients who go for surgery, if you check their blood pressure while they're sleeping beforehand, already 1/3 of them have a MAP below 60. And that's what I was saying, is that different people run at different MAPs, kind of your autoregulation range differs by person. So I always do this for every critical appraisal I do. Did they answer their research question? I don't think they did, because their methods didn't allow them to. They wanted to check mortality when comparing permissive management with targeted management. I don't think they really should have looked at mortality. They should have looked at other things like delirium, length of hospital stay, maybe an AKI. And would it change my practice? It wouldn't make me try and use a more relaxed blood pressure management strategy. It would make me more relieved, I guess, that I'm not going to give my patients an AKI if I don't aggressively fluid resuscitate them, because they've summarized that. And I think actually it's really dangerous they published this, because if you read the headlines and you see a meta-analysis, 9,000 something patients, permissive management doesn't make a difference in mortality but reduces length of stay, that's quite dangerous. So just for interest, I don't know if we have time, maybe a minute, but I'll show you. A lot of people wrote letters to the editor in the BJA. I'm only going to include the negative ones. There were a lot of positive reactions to this as well. People wrote saying, oh, this was a very interesting paper. We note the findings. That's it. So yeah, but here's a couple saying that their concerned readers might draw invalid and harmful clinical inferences. Another one that says, we wish to thank the authors for working to address this important topic. However, we propose there are several flaws. Our analyses were conducted in R via RStudio, and they've actually published it on GitHub, their analysis, and they've said that the results they got from the exact same data set were completely different. So that's embarrassing for these guys. And then here's probably my final slide, but there's an interesting letter to the editor by a research group that are starting this trial. They are looking at person-specific cerebral autoregulatory range under a GA, and they're showing two different patients, patient 1 and patient 2. And you can see that patient 1 has an optimal perfusion range between 63 and 79, whereas patient 2, theirs is totally different. It's between 76 and 113. So if you used a MAP less than 60, it would cause cerebral hypoperfusion in both patients, but like actually, it'd be really much worse in one compared to the other. So yeah, that was a nice illustration. But they're showing you here that even if you tolerate a MAP before a GA, after a GA, you might actually need a higher MAP because of the effects of a GA. Okay, I just also wanted to comment on the fact that intraoperative hypotension doesn't actually have any specific definition. I don't know what you guys think it is. If I say your patient was hypotensive intra-op, would you say below 60, below 65? There isn't. And then there was a systematic review done where they surveyed this between anesthetists, and 140 definitions they got from people. So people define hypotension intraoperatively very differently anyway. So it's kind of hard to give that headline and do that kind of paper. Okay. Some people report it as a change from baseline, and some people just report it as a number. Yeah. So that's it really. Okay. Don't know if anyone has any comments or wants to say anything. Stop sharing. That's the end of journal club. No problem.
Thank you very much for that. I think that shows how not to do an RCT.
Yeah.
Or more importantly, what happens if you draw conclusions from poor data that goes into it.
Yeah.
Certainly won't be changing my practice.
No.
Do you have the QR code for people?
No, I don't actually.
I'll see if
Well,
I
I
can get
didn't
in
expect
chat.
anyone to come, you guys. Thanks for coming to sit. Oh, what's that? There it is. This one. Oh, okay. Okay, this one. I don't know if this is gonna work. Is it? Can you see this? I don't know.
You can take a screenshot, a snapshot of it.
Yeah. Yeah, I could do. Okay,
I've put it in the chat.
I'll put it in the chat. Oh, but you guys can.
Have something of interest. Have something of interest after lunch. Yeah, really fun.
Did you guys find it? The link.
Yes, we did.
Even when I was- Oh. There's one here. Type in folders or something. So neat. It's in there. Oh, definitely not. That's my handwriting. Oh, they have given one. Oh no. Have you guys seen Evie? Yeah, awesome. Evie.